Good afternoon, everyone. My name is Gráinne Gleeson, and I'm here to welcome you all, we're about 96 people, which is very exciting, to our first cervical check lunchtime webinar, Lunch and Learn. Today we have a presentation from Dr. Sarah Fitzgibbon, who is our cervical check primary care advisor. And I think you're really going to enjoy today. We're going to give you an overview on the HPV infection and just give you the opportunity as a reminder of the changes that have happened in the program over the last couple of years, and probably more importantly, give you an opportunity to ask questions. I think that's the good thing about these. So next slide, Rachel, please. Just some house rules before we start. So look, all of the information we're going to present to you today are, they're gathered from trusted sources and obviously relevant for today. We know in the future things may change. And what's important to note is use this as an aid, but obviously there's nothing here that is going to replace your clinical judgment. If you have any queries, with respect to the program, the HPV tests, HPV, always do contact us, and we can talk you through any queries that you have. Important to note that today is a recorded event, and that will mean that this presentation will be available for people who can't make it today. So that's also important. I see some questions coming up already around technical things. So if you have any technical questions, if you just send it to the host and panelists and not to everyone, and then one of my team will get back to you on the technical answer. But the Q&A function is important. So if you have any questions as Sarah is talking through, do type your question in there and then, and either one of the team will answer or we'll review it at the end, because if it's a question that's popping up quite a bit, what we'll do is we'll take that as a theme, and we'll come back to that at the end. As always, we'll be looking for your feedback on this. This is the first one of these lunchtime lectures, and Rachel and her team have a series of these over the summer, but just make sure you're letting us know how they're going. Are they working? Can we do it better? And finally, enjoy the webinar. I think this is an exciting approach. The program is working really hard to get better with our communication. This is one way of doing it. So I hope you enjoy the presentation. I'm going to hand over to Dr. Fitzgibbon, and I'll be here at the end of the Q&A as well. So if there's any questions aimed at the program that I can answer, you'll see me at the end. So thanks very much, and over to you, Sarah.
Thanks a million, Gráinne, and you're all very welcome, everybody. Delighted to have you all here. I hope that you're taking the opportunity to have a cup of tea and a sandwich at the same time. And I really do hope that you find today's presentation useful. As Gráinne has said, any questions that you feel that we don't cover, or anything in particular at all that you would like to know further around HPV or anything to do with cervical screening, we're always really, really happy to hear from you. And we'll give you contact details at the end, and also a feedback sheet so you can let us know how today has gone. So I'm just going to share my screen there, and I'm going to look at Gráinne to see if she can see that. And she, yep, perfect, great. And hopefully we'll be going into our full screen there now as well. So good, hopefully all technological things going according to plan. So that's always a good start. So as Gráinne was mentioning, today we're just going to talk a little bit kind of broadly around HPV infection. I know many of you know a lot, and since the introduction of primary HPV program, which is 2 years ago now, March 2022, 2020, even though, as we know, we didn't really get going with it until July 2020. We're a couple of years into it, and so a lot of us have been meeting women in the surgery coming in for their screening test and asking us questions around this changeover to primary HPV testing. So hopefully we might cover some of the questions that come up, and talking a little bit about communication around that. So I suppose why HPV is important when it comes to cervical cancer, the role of it in the pathogenesis, how cervical cancer develops. But I probably more importantly today, just talk about the effective communication around what it means to have HPV infection and normalizing that for people, because it is quite new. It is something that they wouldn't necessarily have grown up hearing their mothers or sisters speaking about, and it really does come to us, I suppose, to make sure that our understanding about what it means for people is really clear. And I'm just going to touch a little bit then as well about prevalence of cervical cancer. Obviously, that's the purpose of any kind of screening program is to try and reduce the incidence and prevalence of invasive cervical cancer, and also to improve the outcomes by ensuring that people are diagnosed at an earlier stage. So HPV, it's common, it is easily detected, and it is transient. So as viruses go, it should be a pretty straightforward and simple thing for us to talk about. It is something that lots and lots of people have. We have a test that really works to find it, and we know it goes away. So on the face of it, you would think, therefore, that HPV infection is something, you know, without too much complication, that we can talk about very freely and openly. And yet we do know that there are a number of questions that people will have about HPV that actually aren't that difficult, or aren't that easy for us to discuss, or for us to speak with our patients about how that they might discuss it with other people. So the first question that comes up is it sexually transmitted? And yes, it is. And we have to bear in mind that we do live in a society, we have lived in a society where things that are to do with sex are not that easy to speak about. And we have to acknowledge that yes, this is an infection that happens when you have sexual contact with any other person. And when we speak about HPV positivity, so a test coming back as positive, we know that it can bring up these types of questions here. So I've been married for 20 years, and I suppose the three dots after that question come to the next two, which is around this idea of, well, if it's from sex and I've been having sex with the same person for 20 years, what does this mean? Does it mean that my partner has been having sex with somebody else? Will my partner think that I've been having sex with somebody else? And these, again, are uncomfortable questions for people to consider or to talk about. And they may not necessarily ask you these questions in a consultation, or it may not come up. They might even feel uncomfortable about bringing them up themselves. And so I think it is important for us to broach these conversations, particularly when we're speaking with people who have a positive test, but obviously ideally before the result comes back. So in our initial screening appointment, that we are talking about the possibility of your result being HPV positive and what this might mean. So we know that the majority of people will get HPV within 18 months of the first time they have sex, so what they call the sexual debut. But basically, from the first time that you have sexual contact, you're most likely to get HPV in those first 18 months. So for most people, that will be in their younger years, either in their teens or their 20s, would tend to be the time that people have sex the first time. And so your chances of having HPV are much higher at a younger age. At the same time, we also know that you could have had HPV at that time. You could have cleared it. At the same time, we weren't doing HPV testing a number of years ago, so you may not have known whether or not you had it in the past. And now you could have a positive test, which can be a reemergence of that infection that you had 20 or 30 years ago. We know that when you are immunosuppressed for any reason, either the natural immunosuppression that can come with age, or for other physical reasons or iatrogenic reasons, medications, that HPV that would have remained dormant in your body for a long time can come to the surface. So this can be a reason why a HPV positive test can happen for somebody who feels that they did not contract it, we'd say, recently. A frequent question will be, who did I get it from? Trying to track down who it might have been from. Again, for somebody who may have had one sexual partner, this can concern them hugely, because they know that it must have come from this particular person. But again, it can bring up the idea that how can you be certain about the sexual partners, and contact tracing and all of those kinds of things. So we need to remember that while HPV is a sexually transmitted infection, we don't treat it in the same way as we do with sexually transmitted diseases, other sexually transmitted diseases. And the reason for that is because HPV is so prevalent. So 80% of people will have HPV at some point in their lifetime. So if you were to try and contact trace 80% of the population, that wouldn't make any sense, remembering that all the people that they've had sex with also have an 80% chance of having had it. It doesn't cause any acute symptoms. It's not an acute infection in the sense that it doesn't cause you any specific symptoms in the days and weeks after you contract it. In fact, for the majority of people, it doesn't cause any problems at all. We know that it is for the small proportion of people who have persistent HPV. So that would be roughly around maybe 20% of people who might end up with persistent HPV, which is HPV that doesn't clear within 18 months. And it is a portion of that proportion of people who may find that they have abnormal changes to their cells as a result. So it is not a sexually transmitted disease. It is not notifiable in the sense that other sexually transmitted diseases are, but it is a sexually transmitted infection. Do I need to tell the people that I've had sex with that I have HPV? Again, coming back to this issue around contact tracing, around the importance of letting people know if you have a sexually transmitted disease, we'll say like gonorrhea or syphilis, which can have immediate acute physical effects. This is not the case for HPV. People will say, well, we use condoms. And again, we know that condoms are not fully protective against HPV. That's not to say that they're not a bit protective, and they are. And of course, we would always encourage people to always use condoms, particularly I suppose, in times in people's lives where they may not have a fully monogamous relationship or sort of within a committed relationship, as it might be known. But you know, condoms do help a little bit to prevent HPV infection, but we know that they can't prevent them completely. Sometimes people might ask, I've never had an STI screen, should I? And again, the answer in that case would always be yes, remembering that a lot of other countries, an annual STI screen is a perfectly normal thing for people to do. And again, you know, for the majority of people, might be in their younger years before they have a committed relationship. So we would always recommend an STI screen. That's not to say that somebody with HPV is necessarily any more at risk of specific STIs than they would be than anybody else who is sexually active, which is again what we're talking about with people who have HPV. It is, you know, the vast majority of the time as a result of sexual activity. People can ask about HIV, obviously HPV, HIV, similar sounding names, and you know, HIV obviously has a lot of fear and concern, again, still for people, particularly people who would have lived through the time when a HIV diagnosis was, you know, potentially a terminal diagnosis. And again, we need to talk a little bit about risks, about the kinds of things that might make people, you know, exposed to any kind of sexually transmitted infection. So general sexual health conversations can certainly be triggered by conversations around HPV. People will often wonder, how do I get rid of it? And they can be, you know, really quite concerned that they really want to get rid of this. I have this infection in my body, how do I get rid of it? And we need to speak to them again about the fact that for the vast majority of people, the infection itself is not harmful. It's not something that you need to be concerned or worried about. It is a great indicator to us that we need to keep a little bit of a closer eye on you. But it does not mean that it's something that's immediately going to do you harm, or even in the medium term. Will I get warts is another question that comes up. You know, some people might be familiar with the idea that genital warts are related to HPV, and you know, the answer again can be anybody who has had sexual exposure to HPV could easily have the type of HPV that causes genital warts, but that the type of HPV that we're particularly concerned about in cervical screening, which is the high-risk HPV, is not the same virus that will cause genital warts. So again, that can be a slightly tricky conversation for people to have to get their heads around that. And another one could be, what about my baby if I'm pregnant? Is it something that's going to pass down? So we do know that there can be some vertical transmission. But again, really coming back to this fact that this virus is not something that is harmful in itself. It's not a sign of any poor behavior. It is not an indicator that there is anything specific that you need to be, you know, extra careful about, other than we have this really, I suppose, the advantage that we have of knowing that HPV is related to cervical cancer, and that it is a great indicator for us who are involved in screening and helping a person to know if they are at increased risk or not of developing cervical cancer. So to say, these are just a small range of the number of questions that we often get asked around HPV, and we know that they can be a little bit difficult, and it is definitely worth thinking about the answers to these questions before they're asked. So HPV is actually a really, really good news story. So it was discovered in the 1970s. So the virus itself was discovered in the 1970s. And then in 1983, Harold Zurhausen discovered the link between HPV and cervical cancer. So this is a massive step forward. Professor Zurhausen got the Nobel Prize in 2008 for this discovery of the connection between HPV and cervical cancer. It was actually, he shared the Nobel Prize with the people who discovered the HIV virus. So both of the things kind of happened at the same time. But what it meant when he made this connection between HPV virus and cervical cancer, it allowed the development of a HPV vaccine. And if we think about the possibility of a vaccine that can prevent cancer, so those of us who might have trained, 20 or 30 years ago, really that would have been unheard of. So the idea that you could get a vaccine which would prevent you from getting cancer as opposed to from getting an infected disease. So this is a massive step forward. And it has given us the opportunity to be able to talk about the possibility of the elimination of cervical cancer, which again is a huge step compared to how things might have been 40 or 50 years ago. So the World Health Organization has set a target for the idea of elimination of cervical cancer, remembering that elimination unfortunately doesn't mean that there would be 0 cases of cervical cancer, that is not within, I suppose, the realms of possibility for a number of different reasons. But the idea would be to bring the levels of cervical cancer to an extraordinarily low level. The global burden of cervical cancer is huge, and sometimes we can forget about that in a country like ours, where we have access both to screening and to really good treatment services. But the global burden is massive, and it's also one of the leading causes of death of young women around the world. So this target for elimination could make such a massive difference, particularly to lower and middle income countries, where young women, particularly women who might be caring for young children, are dying of this disease in far greater numbers than they are in the higher income countries. So the target is that 90% of girls around the world would be vaccinated by the age of 15. That 70% of the eligible population, so women and people with the cervix, would have at least one screening test by the age of 35, and ideally another one by the age of 45. So that's the WHO's ambitions, is really that you would have one screening test by 35 and ideally another one again by the age of 45. Again, that's quite different from what we have the ability to have more screening tests than that here, but they're recognizing that simply by having those 2 screening tests in your lifetime, along with vaccination and along with treatment, that we will be able to progress towards elimination of this disease. So the third branch of the program would be making sure that 90% of people who were found to have pre-cancer were treated, and that those who had invasive cancer, that 90% of them were managed appropriately with surgery, radiotherapy, etc. If we were to think about, again, in our country, if only 90% of people who were diagnosed with a cancer had any kind of treatment, that seems unusual to us. We would always treat or manage or deal with appropriately 100% of people that we know have cancer, but that's not a realistic possibility in some other countries. So the bottom line is, with HPV, it is better screening and it is less often. So this is, without doubt, good news for the world's population of women. If we look at HPV now, between using HPV versus our traditional cytology, which we would have had up until March 2020. So we know that screening with cytology prevents 75% of invasive cancers, whereas HPV can prevent up to 90% of invasive cancers. If we look at the false negative, so if you're looking at the image over there on the right, so for every 1,000 women screened, we know that around 20 will have precancerous changes. So a small proportion, but a significant proportion of the 1,000 women screened will have precancerous changes. The HPV test will correctly identify 18 of these women. So there will be 2 women which the HPV test cannot identify. But with our traditional cytology test, 15 women of those 20 would have been identified, which meant that 5 women would have gone unidentified. And that is just the nature of the screening test. There is no cervical screening test that prevents 100% of cancers. So we will never be able to detect all 20 of those women. But the HPV test, we will detect 18 out of 20, as opposed to our 15 out of 20, which we had previously. So this is, the basic fundamentals of a screening test is like a very, very large sieve. You have a massive population of people who are potentially at risk. You put them through this sieve, and what we're trying to do is to find those people who we believe to be at increased risk. We take those people who we believe to be at increased risk and then carry out further tests for them. We are then narrowing them down again to find out if that increased risk is indeed true, or if they have any of the changes that we're looking for, and if they do, that we manage those appropriately. So we're taking a large population, bringing it down to a smaller group of people who are at increased risk. And that is what we are finding when we're finding HPV positive people. We are not finding people with cancer. We are not finding people who are definitely going to get cancer. We are finding people who are at increased risk. We are sieving those out from the rest of the population. And we are dedicating our time to making sure that those people with an increased risk are managed in a way that is most appropriate, and that is going to identify those who have precancerous changes and ideally prevent them from going on to having invasive cancer changes. This is just, I suppose, an infographic of how Cervical Check, the program, does this. And the main part of what the program does is really about inviting people, so finding the people who are eligible, sending them letters, encouraging them to attend then to GP practices, to ourselves in primary care, to attend for their screening. And then, depending on the results, then managing them accordingly. So those who have normal results can go back into the cycle of being invited at intervals that have been decided through evidence and through research to be the most appropriate. And then identifying those with the abnormal results and then managing them appropriately, most commonly going on to colposcopy. So with our HPV primary program, what we're doing is detecting those who are HPV positive. They have their tests, then their cytology done on that initial test that they have had done if it's HPV positive. The cytology may be negative. There might be no sign of any abnormal changes in their cells, but we know that we need to check them again next year in 12 months' time to see if they're still HPV positive. If they are still HPV positive 1 year later, and their cytology is still negative, so there's still no indication that there's any changes in their cells, we'll still send them to colposcopy. Because again, we refer back to our previous slide, we know the cytology isn't always definitive. We know that you could have negative cytology, and potentially when you go on to colposcopy to have your further investigations, that there may in fact be some signs of CIN or neoplasia. But again, this is just highlighting how the HPV test is giving us that extra layer that we wouldn't have had previously. So if we had just a cytology-based test, the women who have HPV positive but cytology negative would have been returned to their normal recall, would not have been identified as higher risk, whereas now we know that they are at higher risk and that they need that extra surveillance. So just again, why is it that HPV infection is so important? And we know that our lifetime risk is 80%, so that the majority of us will have had HPV, but the majority of us will get rid of it. For less than 20%, it will persist. The HPV, for whatever reason, isn't fought off by our immune system or isn't got rid of. We know that that's a little bit more likely to happen if you smoke. And in that case, the persistence of the HPV can result then in the virus integrating into the host DNA, and then tumor suppression genes, etc. Things happen that result in uncontrolled cell division, and precancer happens. So again, the infection itself is very, very common, but persistence of HPV is not as common. But this is what we're watching out for. We know that this is the risk factor. So when we're talking with people around HPV, we are recognizing that it is responsible, HPV persistence is responsible for about 99% of squamous cell cancers, but not quite as much of the other types of cervical cancers, particularly adenocarcinomas and glandular type cancers. They are less likely to be related to HPV. Some of them are, but they are less likely to be. When a person gets a HPV negative result, that is incredibly reassuring. So what this is saying is that your risk of, certainly of developing a squamous cell carcinoma is minuscule, but your risk of developing any kind of cervical carcinoma, bearing in mind that those other types of non-HPV related carcinomas are really quite rare. So if you are HPV negative, that is really, really reassuring. And our intervals of 5 years are actually generous. So some countries who are using HPV screening have extended to 10 years, because we know that if today I'm HPV negative, that even if I was to become HPV positive tomorrow, the chances of any abnormal changes in my cells happening within 5 years is tiny, and even within 10 years is still very small. So the natural progression of cervical cancer and cervical intraepithelial neoplasia, you're looking at 10 to 15 years of HPV persistence before that happens in the majority of cases. So when I got my HPV negative result in March of this year, I was delighted with that. I felt that I can happily wait for 5 years. This is something I do not need to think about in my life. Being HPV positive does not mean that you have cancer, does not mean that you're going to get cancer. And even if you were going to get cancer, it's unlikely to happen quickly. But what it does mean is that you do need increased surveillance. So it's flagging you up as being one of those people who's come out of the sieve who needs that little bit of extra looking after. And that is what the program is here to do. We know that about 1 in 10 tests will be positive for HPV. So when we're speaking with people about what the result is going to be, it is reasonable to say to somebody, well, actually, the chances are that your result is going to be negative. However, there is a chance, there's a 1 in 10 chance that your result is going to be positive. That number is going to be higher for younger women. So in the women in the 25 to 30 category, you're going to be more likely to have a HPV positive result for the reasons that we spoke about earlier. At the same time, interestingly, as the vaccination effect comes in, so it's the younger women who will be, I suppose, benefiting from being vaccinated. So people born from 1993 onwards will have had potential to have HPV vaccination. And so actually their rates are going to come down. And so proportionally, the rates of the older people are going to go up. But as it stands, roughly at the moment, and until the vaccine rates fully catch up, it is more likely that the women in the younger category will be HPV positive. We got to remember that any kind of sexual contact counts. So we would, often we live in a very, very traditional society where our idea of sex is penetrative, what's known in the trade as penis and vagina sex. And when we're speaking with patients, we might be inferring that that is what we mean. When they're speaking with us, they might be understanding that that is what we mean, and that we might be talking about, what a younger person might describe as full sex. But we're not. We're talking about any kind of skin-to-skin contact between one person and another person's genitals. And I suppose we just need to check our own biases a little bit around how we deal with something that is related to sex. And again, it can be more difficult for some people more than others. But we do need to bear in mind that we are talking about screening for something that happens to women who have sex. It happens more often to women who have sex who also smoke. These are the kinds of things that people can sometimes have unconscious biases about, and we really need to bear that in mind. We can sometimes tiptoe a little bit around the fact that people who have more sex are a little bit more likely to have HPV. That's just the fact of the matter. But do we make judgments based around that? And we just need to tune in a little bit to what we feel ourselves around HPV infection, around what it means to talk about sexual contact of, we'd say, a non-traditional kind, all of those kinds of things. So it's just something to bear in mind. Just looking at this survey, this information is from a couple of years ago. So looking at people's awareness around HPV virus. And I suppose understandably, it is new. It's not something that people would have been listening to or hearing about up until recently. And so the lack of knowledge about HPV virus is highest amongst women aged 45 to 60. So really, it's up to us to make it something that we're comfortable talking about, that we're very familiar with, and that we are able to answer questions that come to us from people who really, this isn't something that they have either grown up with or that has been sort of in their environment to speak about. These are just some key dates that can be useful to consider. If you think about it, that the screening program really is quite young. It's only 14 years old, so the formal screening program began in 2008. Anybody who's had a screening test before that, so somebody might have missed 1 or 2 screening tests and they might come back into you now, they really have a very different perception about what cervical screening might mean. So just bearing that in mind when we're speaking with people about cervical screening, we are so used to dealing with it all the time that we have a reasonably good idea of what it means, but we need to bear in mind that is really quite recent behavior, that we would do this organized programmatic screening tests. I mentioned earlier that people who are born from 1993 on, so sometimes again in practice I find this useful if I'm looking at somebody's date of birth and I see that they were born in 1993 or after, I know that they would have had the opportunity to have HPV vaccination either when they were 12 or 13 in first year, or there was a catch-up program for people a bit older. We know that the minister has very kindly recently announced that there will also be a catch-up program for women up to the age of 25. So again, they would be a slightly younger cohort for those people in that time frame since who were born since 1993 to be able to catch up with their HPV vaccine. The program extended its screening interval when we changed to the HPV primary program back in March 2020. The screening interval was increased up to 65, but we just sometimes need to bear in mind that was only for women who were under the age of 60 at the time that the HPV primary program was introduced. So again, I find the maths of that a little bit hard. So the way I remember that is that if a woman was under the age of 60 on the 31st of March in 2020, then her date of birth must be the 31st of March 1959 or later. So if somebody presents to you and they were born on the 31st of April 1959, then they are eligible to have tests up until the age of 25. If they were born on the 3rd of March 1959 or earlier, then they are not eligible for tests up to the age of 65. So as I say, that could just be a little bit confusing at the moment. And just a reminder that it was March 2020 that we changed over from primary cytology to primary HPV. So anybody whose previous test was before March 2020, they're still working in that old frame of mind. And these are the people, I suppose, that this will be when they present for their HPV test. This will be their first time they're having a primary HPV test. So those are the people who are more likely to have the questions or concerns around HPV, or that we might take the opportunity to spend a little bit of extra time with them. So just wrapping up a little bit, just coming to, I suppose, the purpose of the whole screening program is to reduce the incidence of cervical cancer, invasive cervical cancer in Ireland. So if we remember that roughly around 280,000 women are invited for screening every year, and around, as we mentioned earlier, 90% of those are going to receive a normal result. The number of people who will have high-grade disease, so we're looking at CIN2 or higher, that rate is roughly in and around 1%. So of your 280,000 people who come to for screening, about 1% will have high-grade disease. The low-grade disease varies between sort of 3 and 8%. But we're looking at roughly around 6,500 women who receive treatment in colposcopy for CIN each year. So this is a good thing. These people have been detected, but we also need to bear in mind that those people who have had treatment have experienced an event in their life that is both a psychological event and a physical event. There is, potential for side effects, for potential negative outcomes when you have any kind of interventional type test. And also, obviously, for some people with more significant treatment, this can have effects for fertility issues, etc., pregnancy. So those are the numbers that we're looking at. Around 150 people will be diagnosed with cervical cancer through colposcopy, so through screening, and roughly around the same again will be diagnosed in symptomatic services. So currently in Ireland, around half the people who are diagnosed with cervical cancer have been diagnosed through colposcopy, through screening colposcopy, and roughly half will have presented with symptoms. I suppose the significant issue with cervical cancer compared to other types of cancers is that it does tend to occur at a younger age. So around 80% of women who are diagnosed will be under the age of 60, and around 60% will be under the age of 50. So that's just a different age bracket than we might be used to with some of the other cancers. Of the people who are diagnosed, nearly 2/3 of them will have some kind of surgery. More than half will have radiotherapy. And traditionally, chemotherapy has had, I suppose, less of a role in cervical cancer than it might have in other types of cancers. And again, we're just bearing that in mind when it comes to thinking about the types of side effects that people might have. The types of side effects from genital radiotherapy can be quite significant. And it can be useful for us to, again, bear that in mind when we're speaking with somebody who maybe has been just recently diagnosed with an invasive cervical cancer. This could change in terms of the chemotherapy, might change obviously with the immunotherapy revolution that we have, which obviously has been great news for so many people with different types of cancers. The 5-year survival for invasive cancer at stage 1 is 95%. So that's pretty good. That's not bad. For stage 4 cancer, it is significantly less. So we're looking at about a 20% 5-year survival for people who are diagnosed with stage 4 invasive cancer. That, I suppose, relative to some other cancers, that is probably a slightly higher stage 4 survival rate, but still, obviously, again, we're looking at a younger cohort. These are the kinds of things that we're trying to prevent. We need to remember that the main risk factors for invasive cervical cancer are high-risk HPV persistence. And as I mentioned earlier, this is more likely for people who are smokers. Sexual history, and again, just coming back to the fact that there are a couple of different layers to this, but what we do know is that people who have, so women who have sex for the first time at a younger age are more likely to contract HPV and therefore to have HPV persistence. People who are pregnant at a younger age are also more likely to develop cervical cancer. Some of this is I suppose, yet to be unfurled, shall we say. And if we think about how research into conditions that are related to women and which are related to sex in women, a bit like I was discussing earlier, probably some of this needs to be teased out. There has been implications around the use of combined oral contraceptive pill, and some of that needs to be teased out as to do with sexual activity or the frequency of sexual activity or the number of partners. All of those things just need to be carefully teased out. But coming back again to the global burden of the disease, if we think about the number of children who are, I suppose, in a position where sexual activity is put upon them at a younger age, in, we say, forced marriages, child marriages, those kind of things, this is coming back to why cervical cancer is such a massive global problem, particularly in lower to middle income countries. And again, as I say, lower socioeconomic status, we know has also is a risk factor for increased rates of invasive cancer. So that was a bit of a whistle stop around all sorts of things to do with HPV, but what I'm hoping is that it might have created some discussion, or that it might have raised some questions for you, and that we would be more than happy to answer. I've put my email address up there, so I'm sarah.fitzgibbon@screeningservice.ie. Always happy to hear from sample takers with any questions or comments or queries, and obviously you can get in touch with program through the usual contacts as well. So I am going to leave it there, and we're going to go back to the panel team here, who hopefully have been gathering all of your questions, and we look forward to talking a little bit more.
Okay, thank you, Sarah, for a really good comprehensive overview of HPV and the changes that we've had in the programme recently. I'm going to introduce Dr. Rachel Comer now. We've had a look at all the questions. The questions are coming in. It's fantastic to get them. Thank you. We've looked, the panelists have looked at the questions coming in, and Rachel's going to give an overview of a couple of things that she's going to feed back live. And I'm going to give Sarah a chance to get a drink of water, and then look at, there's a couple of outstanding questions that we want Sarah to go back and answer live as well. So over to you, Rachel.
Thanks, Louise. Hi, everybody. My name is Rachel Comer. I'm manager of the Screening Training Unit. Great presentation. I'm just going to mention a few different things that sample takers can do to make a difference. So women need to make an informed choice, as we all know, about participating in cervical screening. So it's important to use open language, normalise HPV's relationship to sexual activity. We need to highlight the purpose of what cervical screening is and isn't. We need to differentiate between screening and diagnostic tests. Screening tests are intended, as we all know, for asymptomatic people, where diagnostic tests are intended for those showing symptoms and in need of a diagnosis. So screening focuses on the test of risk rather than establishing the presence or the absence of disease. So in cervical screening, the HPV test is our test of risk, and it screens for the 14 high-risk types of HPV that Sarah has talked about. So we need to emphasize the benefits of screening. So screening saves lives, it identifies HPV before it causes cancer, and helps identify cell abnormal changes when they're easier to treat. We also need to explain what the limitations of screening are. So what it does prevent, it does not prevent all cases of cervical cancer. Cervical cancer can develop in between screening tests, which is why symptoms should never be ignored. Symptoms like irregular bleeding, spotting, or discharge, excessive discharge, you should contact your doctor without any delay. So screening is for women without symptoms and is not appropriate test to investigate symptoms. As Sarah mentioned, we need to normalise HPV infection. We know that HPV infection can occur from any type of physical or sexual contact of the genital area, not just penetrative sex. Sexual contact includes skin-to-skin contact of the genital area, vaginal, oral, anal, or sharing sex toys. Research reports that even having one partner means they still have an 80% chance of contracting HPV infection. We know that some women may only have had one partner and might have had previous negative screening tests. They might question, why do they need to attend because they haven't had a new partner. So we need to emphasize the ability of HPV infection can lie dormant for many years. If it is dormant, it is clinically insignificant and will not cause problems. But that's why we screen every 5 years, as HPV may become active. The most important thing we need to highlight is that most people's immune system clears HPV from their body within 18 months without any treatment. And for some people, the infection remains, and this is why we repeat the HPV test in 12 months to check if the infection is gone. Numerous research studies demonstrate that in the absence of HPV infection, it is safe to repeat the next screening test in 5 years. Without HPV infection, abnormal cells typically return to normal without intervention. Sarah also mentioned, and I'll have to look at the date again as I keep on forgetting this, that sample takers can also do a database search for all women born after the 31st of March 1959 who are between the ages of 25 and 65, because these women are eligible screening age. So just to confirm eligibility within the Cervical Check website, just to make sure they haven't had screening done anywhere else. We also had a question about menopausal women, because we know that women over 50 has the poorest uptake in screening. So we need to be aware that after menopause, the vagina may be dry and atrophic and making introduction of the speculum more difficult. So we need to choose an appropriate size speculum, apply water-based lubricant to the middle third of the shaft of the speculum, and don't apply lubricant to the tip of the speculum, as this can interfere with any lab analysis. So remember, one bad sample taking experience can become a deterrent for women to return to screening again. So ensure her comfort throughout the procedure, because that's of paramount importance. If it is apparent from the initial consultation that she has symptoms related to vaginal atrophy, then a course of vaginal estrogen should be offered. So the duration of the course is dependent on the severity of symptoms, but a good rule of thumb should be to prescribe a pessary such as Vagifem twice weekly for 6 weeks, stopping 5 to 7 days before a test is due, in order to ensure there's no trace of pessary remains at the time of the test. So that's really all of the questions that were asked during your talk, Sarah. So we might go back to Debbie just to see, did anybody populate any more questions in the question and answer function? Or back to Louise.
Hi, we've been looking at the questions we have been answering as we're going along. I think Sarah's going to answer one live now herself on the effectiveness of getting HPV vaccines for women who are HPV positive. And where's the other one? There's quite a lot of questions. Do you see the other one that you're going to answer live, Sarah?
Yeah, no, it was actually the one in relation to referring to colposcopy with this cervix. I was going to go with at the moment, Louise. So just a question that has come in. Can we
thank you.
Sorry, thanks, Louise. So can we now refer directly to colposcopy if we see a suspicious cervix? Previously have been advised that as colposcopy clinics were overwhelmed with inappropriate referrals, we should refer to gynae and only refer to colposcopy if advised by cervical check based on results. So that's a question that has kindly come in. So this is a really important question. And what it comes down to is, I suppose, remembering that colposcopy services are for cervixes that we feel may have cancer in them. So if we're talking about a suspicious cervix, so a cervix might look abnormal for any one of a number of reasons. But if you're looking at a cervix and you genuinely believe that this cervix could have cancer in it, then our recommendation is that that person should be sent to colposcopy and they should be seen very quickly. And the best way to do that is to contact your local colposcopy service by telephone and to say, I have seen a cervix that I genuinely believe, from looking at it, that it probably has cancer in it. So remembering really how rare that is likely to be. So not many of us are going to see cervixes with cancer in them, thankfully. And that can sometimes make us a little bit uncomfortable and a little bit nervous. So we see something that is a bit off and we're thinking, oh, I'm not sure. I'd rather have somebody else have a look at that. And that's perfectly legitimate. But we need to remember that a cancer, when you see it, is really obvious. A little bit like when you find a cancer in any other place. If you find a lesion and you feel it a bit like a breast lesion or any other lesion, and you think, oh, okay, I really don't like the look or feel of this, that is the person that you're going to send acutely to colposcopy, and the colposcopy clinics are going to be really happy that you've done that. For a cervix that just looks a bit off, but you couldn't say that it looked malignant, you couldn't say that I was definitely sure that this looks like something cancerous, then that is what we are recommending should go to symptomatic gynae services. So a cervix could have a polyp, the cervix could have maybe some Nabotnia follicles that you're not quite sure about. It could have an appearance to it that isn't quite perfectly pearly normal, but when you're looking at it, you're making the clinical judgment, well, actually, I don't think this is necessarily a cancer. Then those are the people that we would recommend that you would send to your gynecology services. So I know that can be a little bit of a tricky one to tease out, but if you think of it that way, do I think, looking at this, that I really am concerned that this might be a cancer, then absolutely that should go directly to colposcopy. And I say, but through phone contact with your local service. Even if you're not sure, you can have that phone contact and maybe speak, talk it through with somebody, because obviously we want to be sure that somebody that is a genuine potential cancer risk is seen as soon as possible. But all of those other potential differences that you might see in a cervix, they are probably, or they are better dealt with in a symptomatic gynae service. We also know the prevalence of access, easily accessible services is variable around the country. So we are 100% aware of that. And there might also be local processes in place where it could happen that somebody who is referred to gynae ends up being seen in colposcopy, which is also a little bit confusing for people. But that is our recommendation, is that a cervix that looks like cancer should go to the colposcopy services. So that's the one I was going to answer. If there's any other ones there that you'd like to bring to me, the question in relation to the HPV vaccination that you mentioned there, Louise, I think maybe Debbie has answered that one, has she? She's come in there ahead of me on that.
Yeah, Sarah, can you hear me there?
I can, Debbie, yeah.
There was just a quick question in relation, 1 second. There was a quick question in relation to explaining how somebody that was HPV vaccinated can still have a HPV positive. I just thought it might be quicker to answer that verbally.
Sure. So I suppose, like with all that,
are you happy to take it, or do you? Yeah.
Yeah. No, I do want to go ahead, Debbie. You give it to us there verbally. That would be great. Can you hear me? No, I'll go ahead. So
Sarah, I'm sorry, I can't hear your response there.
That's okay, Debbie. No problem. So we know that not every vaccine is 100% effective. We're very familiar with this concept, I suppose, in the last couple of years that you can be vaccinated. I'm not sure if I'm still audible to you there. I apologize for this. If anybody can tell me that they can hear me or not, that would be great.
I can hear you now, yeah.
Super, sorry about that.
I can hear you, Sarah.
Great, thank you. So not every vaccine will be 100% effective. We also know that depending on the type of vaccine that a person might have, they will not have been vaccinated against all the potential high-risk strains. So the first vaccines that came out were protective against 4 different strains, and the more recent vaccines are protective against 9 different strains. But there is always the risk that a person could be diagnosed with a HPV strain that is not covered by the vaccine, or that if they have had a vaccine that covers that strain, that it's not going to be 100% protective. So that would be the case with all vaccines. I hope that, sorry, slightly disjointed answer covers the question there. And just having a quick look at the
so the Vagifem dosing, I suppose, is each GP, but was there a Vagifem dose given, Rachel, in your talk?
Yeah, I said the duration of the course depends on the severity of the symptoms, but a good rule of thumb would be prescribe the Vagifem twice weekly for 6 weeks, stopping 5 to 7 days before the test. Do you know the dosage, Sarah?
So for Vagifem, you're looking at, and I get this confused because they changed the doses. So it used to be 10 milligram, and then the 10 milligram dose was unavailable. But you're looking at 1 pessary either twice a week or 3 times a week. Remember that there are the other options as well in terms of Invagus and Ovestin. So again, that would depend on the severity of the symptoms and also what would suit a person. So some of them come in a pessary with an applicator, and the Ovestin is a cream which can be a little bit messier, but for some people they might find that a little bit easier to apply. So it really, the prescribing person would have the opportunity to speak with the woman to find out which one is likely to cause the symptom there.
We have another question relating to that topic there. If a lady has had a hormonal breast cancer diagnosis, would you still prescribe Vagifem prior to taking a cervical screening test?
So again, it's really important to remember that for the vast majority of people who've had a breast cancer diagnosis, that there is no contraindication to them having vaginal estrogen. So we know that a number of women who've had breast cancer are often, I suppose, maybe put in a position where they're not offered vaginal estrogen for their genitourinary symptoms of menopause, which many of them obviously will be experiencing quite significantly as a result of their treatment. So it is really important that we are offering vaginal estrogen to women. Even with a diagnosis of breast cancer, there are there's minimal systemic absorption from the vagina, from the vaginal estrogen. And so the vast majority of people with breast cancer can have vaginal estrogen.
Lovely. I'm just going to finish off. There seems to be a few questions in relation to specific HPV vaccination questions. And I suppose just to say that all those questions are dealt with on the immunisation site. Screening is our secondary prevention and vaccination is our primary. So even though we do discuss HPV vaccination with cervical check, those questions would be dealt with directly from your vaccination site with immunisation.ie.
I think one of the questions,
Sarah, I think that's it from the questions point of view.
Sure, yeah, there's just maybe just one or two there that I'm just spotting in the chat. Just the question relating to the HPV vaccine catch-up was when it was going to be starting, and we actually don't know yet. That's my understanding, that the minister announced it, but we don't actually know when it is going to be rolled out. And just another question that somebody had asked about a wheelchair user: how could she go about having her smear test taken if she's unable to get into the couch in the surgery? And for those cases, and for people for a number of different reasons, they might find it difficult to have a screening test taken in a primary care surgery environment. We have been working with our colposcopy colleagues, and the colposcopy teams would be happy to discuss any particular case of somebody who is having difficulty access to screening locally in the primary care setting. And our colposcopy colleagues would be happy to help out. Once again, telephone conversation is always worth having to just explain the particular difficulty that person might have in terms of screening. And the other, do you still take a sample if you think the cervix is cancerous? So that's just another important question. If you think the cervix is cancerous, we would recommend that you do not take the sample. So again, you're looking at a cervix, you genuinely believe this could have a cancer in it. That person needs to be seen in colposcopy ideally within the 2-week time frame, which would be very common, and oftentimes it's even within a couple of days, depending on your local service. So you don't.
Sarah, I just see another question there on the chat function. Just wondering if there's any plan for e-referral, health mail for referral to colposcopy. Would Grania be able to take that?
She might, but I'm also happy to. I know I do like to talk, as you know, Rachel.
Grania, I think Grania's there anyway.
Yeah, so absolutely. One of the things that we're working hard within the program is to try and look at how we can make processes more streamlined and more effective. And even from a GDPR perspective, having paper forms is risky to us, to women, to you guys. So one of the things we are looking at is looking at an e-referral. There's two options for us. One would be an electronic referral from you to the colposcopy units, or an alternative might be direct referrals from the program based on the lab recommendation. So we're looking at the viability of these projects. We'll work closely with primary care advisory group around what's the better option. So yes, it is something that we're looking at. It is important to the program. There's lots of reasons why we're 2022. We should be slightly more moving away from paper for sure. So it's not an easy project. We link with HealthLink as a supplier, and that can be challenging sometimes with their workload. So it is something that we're looking at, is a long story short.
That's great. On behalf of the screening unit, we'd really like to thank Dr. Sarah Fitzgibbon for an excellent presentation. I also, during the presentation, I put up a link. I'd love to hear your feedback and what you thought of the presentation, and any future topics that you would like a webinar on would be great as well. And while I'm here now, I'm just going to share the schedule of events. Hold on a second, just to show you what we have planned over the summer months. We have 2 planned every month.
Rachel, just whilst you're looking at sharing that, I think there was a huge volume of questions on the HPV vaccination. So I suspect we may link in with the NIO, because yes, it's all very well saying go to the website, which of course people can do, but maybe we'll do something in conjunction with the National Immunisation Office, because there's a lot of questions coming in, particularly around the boys, the men, the boys actually. And I don't want us to be that organisation that say, that's not us, go elsewhere. So I think we may look at doing something with them. Yeah, I think there's
and
value
actually
in that.
Dr. Laura Heavey is going to give our presentation on the 7th July on principles of screening. So she does touch a bit more on HPV vaccination and will be able to address a lot of the questions. So please, if you have not already registered for the principles of screening, I think you'd find that one very interesting. Just to go through what we have planned. So the 22nd of June, we've got cervical cancer treatments and support, and that's going to be delivered by a clinical nurse specialist in the Mater Hospital, Miss Sarah Bilton. And then we've principles of screening by our public health expert, Dr. Laura Heavey, in cervical check. And then on the 13th July, we have the cervical check and the national screening program, which talks about the roles and responsibilities of cervical check, and obviously of you as a sample taker as well. On the 4th of August, we have the cervix, so recognising the normal and abnormal cervix. We've actually very high numbers already registered for that webinar. It's going to be delivered by Dr. John Price. And then on Wednesday the 10th, we're doing a webinar specifically really targeting the non-primary care settings, gynae, colposcopy, the gum clinic and Satu. And as I said, if you fill out the feedback sheet, if you have any topics that are specifically interesting you, please let us know, and we'll have a new calendar of events advertising the webinars for the September, October, November and December. So thank you very much for joining us. Everybody that is registered today will receive a link. So this is a recorded lecture, as we've said, so you will be able to watch this again. Okay, and please get us in touch if you have any further questions. Thank you.
Thanks everybody, and take care. Thanks so much for spending time with us at your lunchtime. Thank you.